Alrighty, thank you very much. We're just going to be moving right along here. Next, I would like to welcome to the stage Sabina Amin from Camden, New Jersey, and Associate Professor of Clinical Radiology at Cooper University Healthcare at Camden. Oh, wait, that's mine, sorry.
I was going to say, I think that's yours. So hi everyone, my name's Sabina. I am probably going to be somewhat of an outlier here, and I will preface this with, I am not, no, but can you guys hear me or not really? You guys can hear me. They can hear me.
Okay.
I can scream really well, it's amazing. So definitely not a researcher. I would say 95% of what I do is surgery all day, every day. So I'm going to say this is a different point of view, and it's amazing to see what people are doing. But there are much smarter people here that can answer a lot of VR questions. So we're going to kind of delve in on the clinical side of what all of these smart people have really done for us. So can virtual reality reduce pain and anxiety in procedures in which we use conscious sedation? So what are we really going to talk about? So we're going to learn very quickly about the Real Eye series by Penumbra. We're going to understand the functions of interventional radiology because more or less, I'm not the type of doctor you want to see. You don't come and see an IR, you see pediatrics, you see a medicine doctor. Define the purpose of the study that we used, how to incorporate the Real Eye series into your practice itself, kind of take a look at our current study data, and discuss a case study of an actual patient. So what is the Real Eye series? Amongst all of the things that we have, it's a real great way to escape reality, right? So you're not in your current location, you're going to somewhere new. Similar to a lot of things in VR. We can use it on a variety of settings with a variety of patients. We've used it in pediatrics, but the majority of our study right now is actually more so in the adult population. It's an intuitive system with self-guided tutorials. Shockingly, the adults use the tutorials more than the younger kiddos. It's clinically designed, so it's evidence-based technology used for a lot of therapies. It's mainly a distraction therapy and mindfulness therapy. So in med school, we didn't really have all these fancy things that we were just talking about, kind of how to do these things. So for me, this was an interesting way to look at distraction and mindfulness to change something, not teach them where we're going or really show them our suite, because my hope is that they don't really remember our suite and they never really have to see our suite again. So the headset itself has a variety of content. The ones that we find ourselves using the most is Breathe, Guided Mindfulness, Recline, and then when we looked back to see what a lot of our patients were doing, it was World Traveler and beach retreats, kind of that distraction therapy, like what else can you do? Breathe is useful for us because what I do is take pictures while someone is awake. So breathing in a very predictable fashion is very important to me. And guided mindfulness is nice when they can kind of zone out. Recline is important because, unfortunately, I don't do things with people sitting up. You are laying flat. So a lot of this VR is kind of shifted and changed when you go flat. So who wouldn't want to go to Rome, right? This is something I say is funny to me when you're with us in the basement of a hospital, getting into a room where you don't really want to be. It's often your first foray into medicine in the surgical field, right? What is interventional radiology? And I'll do this very quickly, obviously, because I think I'm the outlier of the group in the room, at least. It's a medical specialty that really looks at minimally invasive procedures. All of what I do is using imaging guidance. So x-rays, fluoroscopy, CTs, or ultrasound. So I don't really cut people open to see what's on the inside. I'm looking at pictures and live x-rays to see where I'm going. Kind of like playing a game, similar to a lot of the haptic feedback we're talking about. We're using millimeters. That's usually the standard of what I use is something in an 018 or an 035, so very small things. We do diagnostic and therapeutic procedures through very, very small incisions, kind of the size of an IV, or a body orifice that you already own, which most people don't want us to go into. So a majority of cases are really completed using minimal or conscious sedation. What exactly does that mean? We'll get into it. So when we're looking at IR basics, I can say we do a ton of procedures, but when we were looking at the use of VR for what we do, we were looking at portacath placement or removal, and you can see in the bottom left corner, that's a port. This is a totally implanted underneath your skin, on your chest, dives into one of your vessel's ports. Now, why do you get a port? You mainly get it in our patients for chemotherapy. So it's not something that someone really wants to have. It's usually the first kind of foray into getting treatment for cancer. We also do it for tough IV access and things like that. But for this study, majority of our patients were newly diagnosed oncology patients. Angiograms with embolizations is a fancy way of saying making a small cut that's less than a centimeter using live X-ray and contrast to see your blood vessels light up on the inside, kind of affecting change, putting a roadblock in, putting therapeutic chemo or radiation or whatever it may be through that. It often involves you laying on our table for an extended amount of time, right? If you're bleeding out, it takes us maybe 30 to 45 minutes to stop bleeding. Or if we're treating tumors, like liver-directed therapy, it can be up to an hour, hour and a half, just by the nature of what we're doing. Conscious sedation, which is really what I wanted to look at here, was a drug-induced depression of consciousness, which is a fancy way of saying, we're gonna give you Versed and fentanyl. One, interestingly enough, is really touted as an anxiolytic. The other is really touted as a pain relief medication, the combination of which we use to kind of decrease your level of consciousness. What's important is you're breathing on your own, your heart's doing what it's supposed to be doing on its own, your blood pressure's doing what it's supposed to be doing on your own, and I should be able to wake you up. Not really what you want to do in a procedure is be woken up or startled or be given directions, but that's the point of the procedures we do. It kind of decreases the risks of anesthesia. So what exactly am I studying, right? Why did I even kind of venture into this? So I run the Department of Interventional Radiology at our hospital. And two things I've noticed is really people concentrate on the opioid epidemic. And we are actively giving medications to people. And while some of my people love the idea of getting Versed and fentanyl, fentanyl has given itself a reputation on the streets, and people don't want it anymore. So how do I do this without getting fentanyl? A little bit different than what they're going to get on the streets, but it's still there. There's a name recognition thing there. And then the other half, which goes with being a head, is that you get something called a Press Ganey score, which is really a Yelp of how your patients feel through this thing, right? Like, did they enjoy their experience? I mean, rightfully so, I would hope, sort of, but really, why do you want to see us, right? This isn't something you choose to do. But it plays a big role in how people choose where they go and how a hospital looks to their incoming patients. So kind of that patient customer satisfaction component and what can I do about pain and pain relief. So the connection between anxiety and the sensation of pain is really pretty well established. There's a bunch of research on all of this, especially for people who are going procedures. The use of VR has been used in some surgical settings, but really limited when we talk about patients who are undergoing minimally invasive procedures, requiring conscious sedation. So we've seen things on, can you use it before venipuncture? Can you use it for something that doesn't obviously need to have full-blown sedation? But getting cut open is not something you're gonna do by going to a beach, right? You're not gonna be okay with someone cutting you open and making space and putting something that doesn't belong there, usually without some level of pain and anxiety medications. So what are we looking at? What did we want to do? So we wanted to look at anxiety pre and post a VR intervention for us, which was 10 minutes. You came in, you met your doc, you signed your consent, you got your IV, which we didn't have a VR headset for because we kind of wanted them to understand what we were doing and kind of see both sides. And then we offered them this. So they took a pre and post questionnaire. We wanted to look at the changes in the perception of pain levels using that analog scale because we can't measure pain in any other way besides happy face, sad face, kind of 1 through 10. And shockingly, for those in research and those in medicine, it's commonplace. This is how we look at pain. There is a pain scale. We wanted to look at the difference in the amount of fentanyl and Versed we used intraoperatively in patients who underwent VR prior to and those who didn't, and then even those intra-op who used VR. We wanted to look at the end user experience for a really kind of interesting video calling interaction that's built into this system. So the beauty of the pandemic, as it's everlasting, is that we've said patients can't bring a lot of their family members down with them. So when they are waiting and there's nothing to do and there's all sorts of things moving around, they're able to remote in someone into their headset for a shared experience, which is kind of an interesting way of saying instead of using a phone to have innocuous conversations all through our pre and post space, they are now kind of participating in a shared experience. So they're all looking at the beach, or they're all kind of going to Rome together. It's a family vacation kind of concept. So background, the cessation of pain has been pretty broadly studied, multifaceted, has the physical components, but as we've talked about, is social, emotional, mental as well. And there's a pretty good study that really shows the relation between emotional states and anxiety and fear with the sensation of pain. You may not really be in pain, but it might be anxiety-driven that causes our body to interpret it as pain. So particularly in the setting of surgery, pre-op pain-related anxiety increases the perception of pain. Doesn't mean that we just hurt you. It just means that you think you're going to relate it as pain. So that in and of itself increases the medications that we give you. If you come in and I say all of a sudden I'm going to take everyone's blood pressure and heart rate in here and we're going to do something about it, a lot of people are going to have artificially elevated blood pressures and heart rates. However, when you go and then put yourself on a table, we think we need to medicate those things to bring it down, to make you less anxiety-ridden. All of these things lead to pretty poor surgical outcomes in the immediate and long-term recovery periods. We throw a lot of pain and anxiety medications. We up a fentanyl dose because we think you need it, or we up an anxiolytic when really we could do something else, and you don't necessarily need the extra injection of drugs. So conscious surgery in and of itself is an additional challenge, right? You are able to hear, and without a VR headset, you're able to see what we're doing. You can see people moving around you, you can hear us talking. It's kind of an odd out-of-body experience, but it heightens people's anxiety. When you know you're there, but there's people milling around, and maybe the conversation is like, what did you see on TV? It really kind of stresses a lot of people out. So several distraction techniques we already know about: music, DVDs, stress balls, all the things that we use to divert patient attention have been used throughout the years. And the studies are kind of mixed. They're overall favorable, but not necessarily the most intense thing that we do. So nothing is commonplace right now in any version of surgery. With the emergence of VR, we're looking at an immersive 3D experience. I don't have people shooting things in corners. They're not moving their arms around because it is very much like keep your arms by your side, keep your arms and legs inside the ride kind of concept. But you want to make them feel like they're not there. So VR has been studied for post-burn therapy, improving pain and anxiety, faster wound healing. We've looked at VR for physical therapy, for rehab, for venipuncture, for common gyne and uro procedures, but not really in minimally invasive procedures, things where we are actively going to be doing something that would otherwise be done solely with conscious sedation. So what we're looking at is, can we alleviate anxiety from these minimally invasive procedures, thereby decreasing intra-op pain perception, not necessarily the pain that we are going to unfortunately inflict when we cut something open, and decreasing the pain medication, which ultimately improves their perioperative experience. So this is the questionnaire that we use, and it's a very common STAI questionnaire. I feel calm, I feel tense, I feel upset, I am relaxed, I am content, I am worried, right? And we're looking at this pre and post a 10-minute VR intervention. So it's not the longest thing. We really, unfortunately, need to get you guys in and out of our room, so I don't have 45 minutes for you guys to zen out. We're looking at retrospective port placements, people who have already undergone port placement without VR, people who are now about to get through a port and are able to use VR, and then patients who will be undergoing any procedure, not just ports. We chose ports because it was kind of an easy thing to do. It was a pretty standardized procedure. It takes me all of 12 minutes to do it, but you spend about 45 minutes in a room. So it's a pretty controlled environment and pretty short. The goal was 300 subjects, 100 in retrospective and 100 in the prospective. And the beautiful green to red is how we measure pain, right? That's our pain scale. This is how we set it up. This is what our procedural space looks like. This is actually my APN, so it's not really a real patient, so I can kind of skip over that. But pretty easy to set up. Obviously has it on his head. We have a nice foam block underneath it, so you're not laying on it. And that's all of the setup we need. We don't really need anything else. Physiologically, we already have you hooked up to an EKG, a heart rate, a blood pressure monitor, a pulse ox. So we can see what's going on there, and we're trying not to medicate solely your heart rate or solely your blood pressure. When we looked at our study, the average age was 48. We ranged from 21 to 70. Like I said, we didn't really include pediatrics in this study. For pediatrics, we use sedation, right? Because if they wake up in the middle of something, I can't medicate them. I need pediatric anesthesia. So it is not the group that we usually do these things with. Anesthesiologists do not like to be put into the middle of a case that's already started and try to sedate someone. Whereas on the adult side, you already have your IV. I can easily push something. Gender, we were 57% male, 42 or 43% female. Caucasian, 71.4%. African American, 29%. So when we looked at the kind of anxiety data, I feel tense and I feel content were where we really saw our biggest differences. And the most common procedure we did when we looked at this was a port placement. So average pain, which was interesting to me, was pre and post 0. It wasn't a pain component. These are patients who were at the beginning of their cancer journey for the most part in this subset analysis, so they weren't on chronic opioids. So they didn't really have that pain concept. So we were really looking at anxiety here. Average medications used in our procedure, 1.9 milligrams of Versed, fentanyl at 82 mics, Dilaudid, and Benadryl, which Dilaudid is a very strong drug, and Benadryl is Benadryl that you all know and aware of, which we try to use to get people to sleep and then not really think about anxiety. Overall experience rating, 71% say it's excellent, 28% say it's good. Interestingly enough, none of our patients who used VR have required post-procedural doses of pain medication. We didn't have to give them more pain meds when they're done, which is a very interesting concept because sometimes just laying there kind of makes you now all of a sudden realize you have something in there that's going to be the start of your cancer journey, and they freak out. So that was very interesting for us and kind of decreased the rate my nurses were running around in pre and post, which was a very happy circumstance for me. Averages of medications are lower in the VR group than when we looked retrospectively as ports. Now, I can't say, hey, we're going to, you yourself, I'm going to give you VR and not give you VR, and we're going to do the same procedure, because usually these people don't need 2 ports, right? It's 1. So it's hard to really connect in that sense. But what we wanted to do is open it up and look at enough patients to see if we can somewhat take a look at a similar type of procedure and differentiate what we used. And no one using VR has rated their experience less than good, which for someone in medicine is fantastic because we're not used to excellent when you see a patient. So this was our case study. She was a 52-year-old female. She was recently diagnosed with triple-negative breast cancer. She came to the IR department to start chemo. So 48 hours before she came to us is when she learned she had cancer. Not a great turnaround to really internalize anything, so anxiety was on a very high level. Becomes tearful as we're even talking to her, right? Because the diagnosis and prognosis are really kind of setting in. She's got 2 children. She really doesn't want to do this. And so we presented this as an option to add to her care. So we don't force anybody to do it. It's not of our standard of care, but it's kind of after we get their consent. Would you consider? Would you like to try out? And most of them, when they're this anxious, in between their tears, kind of wipe them down and say, let me give something a shot. So this was her pre and post questionnaire. So I feel calm, went to very much. Mind you, we haven't done the procedure yet. This is in pre-op. So nothing has changed besides a 10-minute go to the beach kind of concept. I feel tense somewhat to not at all. I feel upset, moderate to not at all. Relaxed, not at all to very much. Content, somewhat to moderatively. I'm not sure who would be content really in this space, but here we are. I feel worried very much to not at all. And when we looked at her mean doses, she had 50 of fentanyl and 1 of Versed. We usually kind of start with 2 and 100 right off the bat to try to woo-saw them because kind of getting everything cleaned, or for men, getting one part of your chest shaved kind of is an odd feeling in front of everybody else. And our pain score, again, was 0 and 0, because she wasn't really in any pain. It was this anxiety component that we were medicating with fentanyl, and fentanyl is a pain med. So now our fentanyl, instead of medicating anxiety, was really because I'm using lidocaine and cutting that. She rated her experience as excellence, and I put it in quote because it was excellence and not excellent. She referred her friend to our department because of cutting-edge VR, right? We didn't do anything different. She put a 10-minute headset on. Little kids use this when they game. But we got people because of this, right? Noted that for an hour, she felt like she could escape her current. She actually asked to use it in the post-op section, which I'm sure is trippy in and of itself because she already had Versed and fentanyl on board, so maybe she was on a whole new ride. She did choose the beach because that is where her and her family visit. And so for her, it was the distraction therapy that really kind of took it to heart. These are some of our references, and I'm happy to answer any questions.